So I'm Dr. Slocum, Robert Slocum from University of Kentucky HealthCare and United States of America. And this presentation is on the narrative medicine applications for neuro-oncology, patient identity, and quality of life. And this is also based on my work as the narrative medicine provider at University of Kentucky HealthCare, and in particular, my work with patients who are referred to me for narrative medicine services. And these are neuro-oncology patients, obviously with diagnosed brain cancer. So just to say, first of all, in this study, I want to offer thanks for Dr. John Villano of the neuro-oncology services at University of Kentucky HealthCare, who was a co-author with me on the two papers that are the basis of this presentation. So the impact of brain cancer and its treatments bring a unique threat to patient identity and quality of life by challenging the patient's essential identity in significant ways, impaired cognitive skills, loss of memory, reduced coordination, altered feeling states, and limited capacity for self-expression. And these can have a devastating and worsening impact on the patient as the cancer progresses and may be exacerbated by treatments. So the patient with an identity of spouse or parent may no longer be able to relate well with their loved ones. This is talking about the impacts again. A patient with an identity of provider may no longer be able to work or have a job. So again, a threat to self-identity. A patient with an identity of a self-sufficient person may no longer be able to live independently or perform activities of daily living without assistance. And this may be due to the disease progression. It may also be due to treatment. Some treatments may cause whatever, dizziness or other impacts, symptoms that interfere with daily living. The patient's sense of self may be greatly challenged by diminished ability to remember important events or people, balance a checkbook, organize an activity, or walk across a room. And these losses, impairments can have a considerable impact on the individual, but the extent and the nature of that impact can only be fully understood by understanding the patient's identity and sources of meaning. In other words, understanding the patient's story. So anyway, but I've basically summarized those slides. So we're talking now about the contributions of narrative medicine, that it considers how to help patients retain and rediscover self-identity during treatment. And the narrative shared by 4 brain cancer patients will be considered in this presentation, along with ways that the narrative medicine sessions encourage patients' resilience and discovery of meaning, and that the sessions made visible contributions to these patients, but I'll detail how that has taken place with further presentation here. So the narrative medicine approach, as I said, very open-ended, dynamic, but there are 4 sort of core questions that I found helpful, especially in initial visits with patients. And they're intentionally stated in the simplest of terms for maximum accessibility, but they can go fairly deep. And so the first of these is to ask about the patient's life story. In other words, what brings you here? And that invites the patient to share the whole story of their illness, initial symptoms, diagnosis, early treatment. Again, I work in a tertiary care center, so in some cases, patients have been seen in an outside hospital or by outside providers before getting to us. But in any case, inviting the story. How did they get here? What's going on? What brought them to this point? What have they experienced? And then asking concerning the patient's sources of strength, or support, what helps you the most. And that's an invitation for the patient to share their own experiences, their own sources of strength. That might be family, it might be faith, it might be a strong support system or treatment team, but to get that from the patient. Third question, do you see anything differently? Frequently, as patients go through the process of treatment, they have new perspectives. Dr. Carl Menninger, American psychiatrist, sort of mid-20th century, talked about the idea that in some cases, patients may come to be weller than well. That is to say, as they go through the challenges of illness and treatment, they may come to a deeper understanding, a deeper individuation in their own lives, a deeper balance than they have known before. This relates to the work also of Dr. Arthur Frank, who talks about narratives in terms of chaos, restitution, and quest. Chaos, the moment of being diagnosed with a potentially life-threatening disease or condition. Restitution, the patient may just wish to be made whole or put back to their original status, but quest, the patient may come to a level of understanding, a sense of growth that may not have happened but for what they've gone through in their process of treatment, or at least not happened for some time, not nearly as quickly. So in any case, do you see anything differently as an invitation for the patient to reflect on the changes they may have experienced during the course of treatment for serious illness? And then finally, what comes next? What do you hope for? Invites the patient to share their hopes for the future. This may help the provider to recognize a future orientation. The patient has a sense of identity beyond that of being a patient, and which is easy in a serious condition such as brain cancer for it just to take over everything, but for the patient to regain their sense of self, their sense of identity, personhood, and to identify their hopes for the future can be very significant in that regard. So in terms of these case studies, the questions were intentionally presented as simply as possible to avoid confusion and to encourage understanding. So the patient's self-reflection may contribute to new insights, goals, and enhanced quality of life as they face their struggle with loss of identity during treatment. Patients may express their hopes and fears along with their best and worst experiences during treatment. Narrative medicine conversations can help the patient to clarify the sense of self, reintegration of self, personal meaning as the patient's story develops over time and during treatment. And of course, this understanding is not only for the patient, but it can also be helpful for the treatment team whose understanding of the patient's goals of care and quality of life may also be very helpful. So that understanding the patient's unique situation is very significant in this regard. So, for instance, a minor impairment to eye-hand coordination for one patient might just be a slight nuisance, but for a patient who is, say, a professional musician, performer, or a brain surgeon, a slight tremor could be devastating for their ability to continue to perform activities or work, vocation that's most critical to them. So again, understanding the patient, their life, their motivation, their sense of self is vital for appropriate treatment and for understanding goals of care. So again, these conversations may help the treatment team appreciate each person's unfolding story and the impact of brain cancer on the patient's identity. The narrative medicine can enhance patient care by improving communication and mutual respect between the patient and the treatment team. In some cases, if there's been a breakdown of communication or misunderstanding, narrative medicine discussions can help to reboot, so to speak, get the conversation going again, help the patient to understand how more effectively to communicate their concerns, help the treatment team to understand what the patient is seeking to communicate. The narrative medicine practitioner can alert other team members to changes in the patient's condition and goals that may lead to additional treatment options. If, for example, the patient has lost interest in activities that would normally be very significant to them, that can be a significant factor to be communicated to the larger treatment team. So narrative medicine methods can go forward in ways that can be helpful for the team. The purpose of the core area questions is to draw out the patient's experience of illness and treatment while identifying their areas of concern or conflict. And unlike an intake interview or other therapies that may be scripted, there is no standard checklist or script for questions in a narrative medicine session. Although much information may be shared, the purpose is not just to extract information from the patient, but rather to build a bond where the patient can share their concerns, can feel heard, listened to, can voice matters that they may have withheld from stating because they thought it wouldn't be understood or wouldn't be appreciated. They were just concerned to be candid to that degree. The narrative medicine approach is patient-centered and open-ended, seeking to build a whole person understanding of the patient, including appreciation for the patient's self-identity, motivation for treatment, and sources of meaning. For these patients, follow-up sessions were held during subsequent outpatient clinic appointments, sort of continuing to unfold the methods of this study as well as its outcomes and conclusions. And occasionally, patients were seen during infusion clinic appointments or inpatient hospital stays. And during follow-up sessions, patients were encouraged to continue to reflect on their story with attention to any changes in their symptoms, possible impact on their lives, sources of meaning, and attention to any changes in the patient's outlook or attitude. So actually, let me pause here for a moment. So this is more about the methods and the general principles of narrative. Now, let me ask, are there any questions based on my explanation of that before going on to the actual case histories? Okay. Hearing none, I'll go on to the case history. So patient A was in the mid-40s, had a left occipital glioblastoma. She had been a prompt employee, dependably on time for many years, but as the disease progressed, she began to arrive late to work without expecting to or intending to be late. This was surprising for her and the people who knew her. Her sense of time diminished as the disease advanced, and she continued to have difficulty with time perception, was unable to tell time from a watch or clock. In the context of narrative medicine sessions, she was able to discuss the meaning of time in her daily life and environment. The family reported she moved very slowly while completing multi-step tasks. Getting ready to go for an appointment or errand would take a long time. The family, though, described this slow pace as turtle time because of the delays. I mean, in a sense, in the best of ways, they were able to inject actually a little element of humor, something that they could smile about, laugh about, instead of just be despairing because of the loss of function that was taking place. And it was possible to encourage this this sharing together, this dialogue in the sessions, encouraging their appreciation of their time together and the quality of life that the patient did enjoy. The second case history, patient B, an early 60-year-old with right parietal glioblastoma. He drew satisfaction from working a full-time job that required technical and analytical skill. He described work with enthusiasm during an initial narrative medicine session. He experienced self-identity disruption as a skilled professional due to loss of balance, vision impairment, which led to mistakes and errors in written communication he would not normally have made. But he found a workaround, so to speak, a trusted coworker who was also sharing in and familiar with his work, so they could check each other's work. So there was an element of mutuality that he could engage, enabling him to continue his work, which again, he valued highly. And that was an important source of meaning in his life, even despite his illness. At a later time, due to disease progression, he was unable to continue his work, but he was still able to read at home, to play cards with his wife, who was very supportive. They took walks together. They shared activities to enhance his quality of life. He brought an analytical and rational clarity to discussions of his life and treatment in narrative medicine sessions. And these sessions and the understanding of his life that came from him made it easier for the treatment team to understand his perspectives, identity, and ways of thinking, facilitating better communication with him. A third patient, patient C, an early 60-year-old with left frontal glioblastoma, admitted to treatment. He became more prone to irritability as the disease progressed. He became annoyed or impatient at times. This was not so much experienced in the sessions as reported, but the patient and his wife both said his personality changed during the course of his disease and treatment, that he became less filtered after his surgery. These behaviors could strain and threaten the patient's close relationships and quality of life, and he was concerned about his behavior and wanted to interact well with his family. This could be discussed in the narrative medicine sessions. He had a good attitude, he was open to help, and his adjustments during his illness and treatment became an ongoing work in process that he could discuss. The patient and his wife were able to discuss his changes during treatment and supported each other effectively. And his narrative medicine visits encouraged their sharing and seemed to enhance quality of life under very challenging circumstances. And finally, the fourth case study, patient D, was an early 40-year-old with grade 3 anaplastic glioma involving his right occipital lobe. He enjoyed mowing the grass and riding his four-wheeler, kind of a recreational outdoor vehicle, off-road. But he chose to stop these activities as a precaution to avoid shaking his head, his brain, or aggravating his headaches. But no one on the treatment team had suggested that was needed. So these activities were important for him, and he first mentioned their importance in the narrative medicine session, which made it possible for me, the narrative medicine provider, not a neuro-oncologist, to talk with the treatment team, his neuro-oncologist, and after a medical review, the treatment team concluded the patient could safely return to these favorite activities, very active activities, without harm. The significance of these favorite activities and their restoration could improve his quality of life during his illness and treatment. As I say, these were only revealed in the context of a narrative medicine session. Understanding his story made it possible for the treatment team to encourage his quality of life by clearing him for activities that were significant for him and not harmful. So in terms of conclusions here, we can say narrative medicine sessions can help patients put their stories into words, sort out thoughts and feelings, identify sources of strength and specific hopes or motivators, and draw insights from the experience of illness and treatment. Narrative medicine can also encourage patient trust and rapport with the medical treatment team and may prove helpful if there's been any kind of misunderstanding or loss of good rapport. In some cases, visits allow the narrative medicine practitioner to share observations with the medical treatment team concerning the patient's clarity, affect, focus, availability for communication, purposive thought, and motivation for treatment. So in this case, these visits made visible contributions for the patients mentioned, helping patient A to explore changing perceptions of time and environment and experience the enjoyment of family support despite having diminished ability to organize and tell time, executive functions, if you will, supported patient B as he sustained a professional identity with the help of a colleague despite skill impairment due to brain cancer, encouraged the sharing in family relationships and support for patient C as he faced behavioral changes that could have challenged his relationships, and finally allowed the treatment team to consider ways to help patient D to recover some quality of life by safely returning to favorite outdoor activities. So that is my presentation on narrative medicine applications for neuro-oncology patients. So let me ask, are there any questions?